Hello and welcome to 2-Minute MRCP. Today, we'll cover acute pericarditis in a simple and exam-focused way. Acute pericarditis is inflammation of the pericardial sac that lasts for less than 4 to 6 weeks. Let's start with the causes. The most common cause is a viral infection, particularly Coxsackie virus. Other causes include tuberculosis, uremia, postmyocardial infarction pericarditis, radiotherapy, connective tissue diseases such as systemic lupus erythematosus and rheumatoid arthritis, hyperthyroidism, malignancy, especially lung and breast cancer, and trauma. After a myocardial infarction, there are two important types of pericarditis. Early pericarditis, occurring within 1 to 3 days, is due to fibrinous inflammation. Late pericarditis, occurring weeks to months later, is called Dressler's syndrome and is autoimmune in nature. Now let's look at the clinical features. The classic symptom is chest pain. This pain is often pleuritic, meaning it worsens with deep inspiration. A key exam clue is that the pain is usually relieved by sitting forward and worsened when lying flat. Patients may also complain of a dry cough, shortness of breath, and flu-like symptoms. On examination, you may hear a pericardial friction rub. Moving on to investigations. The ECG is very important. Unlike myocardial infarction, ECG changes in pericarditis are usually widespread or global rather than confined to a coronary territory. The classic ECG finding is widespread saddle-shaped ST segment elevation. The most specific ECG feature is PR segment depression. Remember this for MRCP exams. All patients with suspected acute pericarditis should undergo transthoracic echocardiography to assess for a pericardial effusion. Blood tests typically show raised inflammatory markers such as CRP and ESR. Troponin may be elevated in around 30% of patients, suggesting associated myocardial involvement, known as myopericarditis. Now let's discuss management. Most patients can be managed as outpatients. However, patients with high-risk features, such as fever above 38 degrees Celsius or elevated troponin, should be admitted for inpatient management. Any underlying cause should be treated if identified. Most patients, however, will have pericarditis secondary to viral infection, meaning no specific treatment is indicated. First-line treatment is a combination of NSAIDs and colchicine. Treatment is usually continued until symptoms resolve and inflammatory markers return to normal, typically within 1 to 2 weeks, followed by gradual dose reduction over the next 2 to 4 weeks. Patients should avoid strenuous physical activity until symptoms and inflammatory markers have normalized. Athletes should avoid intense exercise for at least 3 months and only return when symptoms, ECG, CRP, and echocardiography findings have all normalized. Thanks for watching 2-Minute MRCP. If you found this helpful, don't forget to like, share, and subscribe to 2-Minute MRCP for more quick revision videos.